Right, so let's make a start. In this session, I've got two of my colleagues from Sheffield who will be speaking about the importance of neighborhood in different contexts in head and neck cancer. It's also my great pleasure to introduce Arthur, who's flown all the way from America and is a close friend and a patron of the Solos. He attends more meetings than me, actually, not being here, so credit to him, and very busy head and neck surgeon. So over to you, Arthur.
Thank you all and welcome. As Ali said, I came over here from Boston, so it's always a pleasure to be here with the Swallows. Last year I did this via Zoom, so it's really nice to be here in person. I want to apologize up front. There's a typographical error. It says neighborhood spelled with the U, and we all know you don't spell neighborhood with the U. So just putting it out there for public consumption here. When I think of head and neck cancer, I think of three main elements, critical elements: the patient, the caregiver, which can be family, friends, and then the healthcare providers themselves. And these three elements really reside within the context of available resources, existing conditions, and extenuating circumstances that to me make up what I would describe as the neighborhood, whether you spell it with a U or not, of cancer care. So today we're going to look at a couple of neighborhoods that really apply to cancer care. We're going to look macroscopically at a large geography, if you will, and then microscopically, truly at a cellular level. And I have two outstanding colleagues here who are going to speak to you today. So first we have Professor Zoe Marshman. She is a professor of dental public health, School of Clinical Dentistry here at the University of Sheffield. She has worked on or published the National Atlas of Head and Neck Cancer. It was published 2 weeks ago with the UK Office of Health Improvement and Disparities. So she's going to talk about variability across geography, epidemiology regarding head and neck cancer, and what I would call the macroscopic neighborhood. Then we're going to hear from Professor Daniel Lambert, Professor of Molecular Cell Biology, School of Clinical Dentistry, also here at University of Sheffield. He reported to me that he was the Dean of the dental school, now he is the Deputy Dean, working with Ali, as we've heard earlier. And he's going to speak about the science of cells, head and neck cancer cells, the biology of head and neck cancer cells, and really look at a more microscopic neighborhood, if you will. Just a little editorializing, I'd like to say, I encourage you during this two-day conference to really look at all aspects of the cancer journey. We've heard some wonderful speakers already this morning, and look at it from the three elements I mentioned, from the patient, from the caregivers, and also from the providers. And the providers is a wide base: speech therapists, language therapists, all of that, not just the clinicians, or not just the physicians, I should say. Look at the innovations, and I'll talk about this tomorrow during my lecture, but look at all the innovations that are being made, not just for survival, but to improve quality of life. And in fact, much of what we talk about ends up being more about quality of life. Obviously we want to cure, it's the quality of life that we really want to improve. And when you look at the kiosks and tables behind me, it really attests to the continuing efforts to improve quality of life in head and neck cancer patients and for their families as well. And a big part of this is I want people to advocate for themselves. And all of what you see here is because caregivers, patients, and providers have advocated for better care for head and neck cancer patients. So we can't just be complacent with what we've done. We've got to keep moving on. And the two wonderful speakers we have today are people who are really at the forefront of doing that. So I'm going to introduce Zoe first, Professor Zoe Marshman. Thank you.
So thank you very much for that kind introduction, and a very big thank you for inviting me to speak today. So I'm Zoe Marshman, and my background is in dental public health, and I work here at the University of Sheffield. So I'm taking the neighbourhood theme of this session, and I'm going to talk about some work that we've been doing across England to look at geographic variation in head and neck cancer. So it's more about, though, maybe less about the treatment side that was mentioned, but more about the epidemiology of the disease. So as part of this work, we looked at things like incidence, mortality, stage of diagnosis, and how those variables have changed over time, and how they've changed for different types of cancer, of head and neck cancer, but also how the geography, the neighbourhoods in which people live, determine very much differences in those key variables. So the work I'm presenting is contained within this atlas. Dr. Kelly mentioned it this morning. So it's the first of its kind to bring together the variables that I've mentioned and to look at it in terms of variation across England. We use the most up-to-date data that we have available that's amenable to this type of analysis, which is just up until 2020. And we had a steering group of experts, of expert patients. So we had Chris involved, of experts in pathology, oncology, surgery, epidemiology, data analysis, and as well as other dental specialties and charities. So please do have a look at the QR code, or you'll find at the University of Sheffield stand a flyer about this. So the work I'm going to present is very much contained within this atlas, and I'd just like to take the chance today to go through some of the key findings, and then to think a little bit about what that means for advocating for preventing head and neck cancer in future. So when I talk about neighbourhoods, I'm talking about geographies, the geographies being the integrated care boards. So you won't be able to pick out the individual names, but this map has got the individual integrated care boards in England. And what we wanted to do was to highlight differences between integrated care boards in some of the key variables that we've included in our atlas. So the atlas starts with some headlines. So before we go into the geographic variation, we have some quite shocking headlines actually, that makes conferences such as this even more essential, because we know that the data that we've looked at shows that the incidence of head and neck cancer is increasing. We also know that the mortality rate is increasing. And when we consider that mortality rates for many other types of cancer are on the decrease, this is particularly important for us to note. We know then that the stage of diagnosis of head and neck cancer is also very late in the context of other cancers, with over 50% of head and neck cancers diagnosed at this late stage. So we've got this sort of increasing incidence, increasing mortality rate, and we've got a disease that's being picked up later, which we know has very sort of important considerations when we think about treatment outcomes for diseases that are detected later. But we also know that head and neck cancer as a broad group consists of many different types of cancer. So I've put some data on the slide just to show how some of that varies between cancer types. So the incidence, the mortality rates are increasing, but one of the things that us in the steering group for this atlas were particularly keen on getting across are these wide social inequalities that you see for head and neck cancer. So for pretty much all of the indicators we included, the rates were double for people living in the most deprived areas of England. So I'm just going to go through, show some graphs and some maps just to illustrate some of these points. So if we think about incidence first, we see, if we look at the data broken down by the area in which the patient lives, so we've broken it down into 5 different areas. For each of the cancer types, you'll see that there is this socio-economic gradient. There's this huge variation in the incidence between people living in the most deprived and the least deprived areas of England. And one of the reasons that was so important for us to focus on in the Atlas is because this part of the variation is unfair. It is an unwarranted variation. We see variation perhaps in age, and we expect that perhaps the incidence of cancer will increase with age, but we do not expect, or we do not need to see these big variations in terms of deprivation. So these is the first of a series of maps that I'm going to show. The maps include the integrated care boards. So you might want to have a look and pick out from the map the area of the country where you live or you work. Because whichever of those 2 maps that you look at, they're slightly different statistically, but whichever map you look at, you will see the variation. The dark areas are the areas with the highest incidence, and the light areas are the lowest. So we can see from this actually quite a north-south divide, in fact, with the areas in the north of England having amongst the highest incident rates. When we look at mortality, again, very similar patterns, statistically significant differences between those living in the most deprived areas and the least deprived. So it's 2.6 times the mortality rate for depending on the area in which people live. And again, perhaps not surprising to see again this north-south divide, and the maps very clearly showing that. Now there are other anomalies that we see in the data. Sometimes there's areas of the country that are showing darker than you might expect. And we've presented the Atlas in this style using maps because we hope that integrated care boards, those that commission the services, will be able to look at these maps and consider how, say, the mortality rates in their areas compared to mortality rates in their neighbouring areas. And that's again important in terms of stage of diagnosis, where really we would expect there to be no difference in stage of diagnosis across geographic areas, but we know, again, looking at the data, that these geographic and social inequalities very much exist. So when we look at the map for the variation, the late stage diagnosis, there are areas of the country where the cancer is being diagnosed much later. And we're hoping that by bringing together this data and presenting it in this way, it will enable those areas to look at, again, what they're doing and what they could be doing differently. I want to just now move on to some of the other indicators that we included, which were about risk factors for head and neck cancer. So we've got different types of head and neck cancer. We've got different risk factors for many of them. But we've also got some health-related system factors that we wanted to look at as well. So for this, we were a bit restricted based on the data that were available, but we were able, as part of the report, to include data on smoking, so self-reported smoking status. We didn't have data on smokeless tobacco though. Some data about hospital admissions for alcohol problems, thinking back to the talk this morning about HPV vaccination, we've got some data on vaccination coverage. And then we're able to obtain data about dental access, so access to NHS dentistry. So some of this data came from local authorities and some came from the authority that records dental access data. So you'll see a few more maps now. Again, we've got this time the maps include the local authorities, so the local government, and we've got the integrated care boundaries in red. So this map very much shows the variation in smoking rates. So this is for adults. Again, quite big variation across the country. The lowest smoking rates are down about 4%, up to about 22%. So very big variation across the country. But you can sort of see already that the places where there was the highest incidence of smoking was also the places in the country with the highest incidence of cancer. You see that again for the alcohol-related admissions. So this was a fairly crude measure of alcohol consumption. It was the only data we could get on this. But again, you can see how the incidence and mortality data relates to the alcohol data, but also the smoking data as well. So we've got groups of the population where these risk factors, the smoking and the drinking, are clustering together, which means they're obviously then at more risk of developing the disease. We were able to obtain, again, which was a bit constrained by the data that were available, but to obtain data on HPV vaccine coverage. So just picked this one map out. We've got females and males, but really quite, again, big variation across the country. And if we're thinking about trying to prevent the disease, thinking about working with schools and local authorities, who are the people that commission the school nurses that do this vaccination program, you can certainly see areas of the country where you think there's a lot of work to be done to increase their vaccination coverage. And then finally, this final map just showing the situation in terms of access to an NHS dentist. So on this map, we're looking for the areas in the dark colour to be the areas where the highest access is. So you can see, actually that's quite good, because the areas of England that had the highest incidence and mortality for head and neck cancer, they are the areas that have the highest access to NHS dentistry, which I think, generally is positive. But because of this increased burden of disease in those areas, and because of this data about the late stage of diagnosis, it does make you think whether actually even this amount of access to dentistry is enough in those areas. So that's the maps and the graphs finished. I'm just going to discuss a little bit about what the reasons for this variation potentially are. And these were reasons that we came up with from the literature, from the discussion with the steering group, and from analysis of the data. And we've categorised the reasons into the population factors, so some of the data that we've talked about in terms of the level of deprivation in which people live, but also that link with the risk factors. And then looking at the literature, we know there are specific vulnerable groups in society. That might be people that are homeless, people that are in prison, who have higher incidence of the disease as well. And those groups obviously require specific and quite more intensive interventions if we're wanting to try and prevent the disease. In terms of the health systems, when we think about the journey from somebody perhaps spotting a lesion to then seeing a primary healthcare professional, whether that's a doctor or a dentist, to then entering into the referral management system and the referral pathway, getting treatment, and then the rehabilitation afterwards. We know that across England there is great variation in those pathways. So some of the variation we see in those maps and graphs is to do with variations in those care pathways. So the atlas, as well as having hundreds of pages of graphs and maps and lots of statistics within it, we've also tried to think of some action points. And by working together as a steering group, we were really focusing on prevention of head and neck cancer. So what can we do to prevent it? So we've settled on these 4 kind of areas where we are tackling the risk factors. So that's tobacco, the smoked and smokeless. And it was really encouraging yesterday to see a new tobacco and vaping bill that was passed in Parliament yesterday. So our suggestions as a result of this work is that we certainly need to intensify the partnership working that goes on, including the national government, the local government, charities, specialist organisations, clinicians, working with patient groups to prevent the cancer by tackling these risk factors. We talked a lot about the need to improve early detection and diagnosis and raising awareness of this disease as a first start in that. And then the Atlas also has a section about gaps in research, because there was a lot of data gaps, there was a lot of gaps in the literature, that when we came to try and look at reasons for this variation, we just weren't able, we didn't have the data, we didn't have the ways of answering the questions. So some of the key gaps that we've talked about things like the awareness raising, how is the best way to raise awareness, particularly with those vulnerable groups in society we know that probably have the biggest burden. We talked about screening and looking at the evidence for the clinical and cost effectiveness of screening for head and neck cancer. And then we also talked about work that's perhaps more lab-based, about risk predictors and biomarkers, and I know that's in Dan's talk that's something he's going to pick up as well. So finally for me, we've produced this atlas now. As I said, it's the first of its kind. We had national and local press releases to try and again raise awareness of the disease and the burden of the disease. So those that was shared a few weeks ago. We've had a lot of interest in that, which is really encouraging. But what we really want is to turn some of these actions into reality. So we've been working with our steering group to make sure they share the findings of the Atlas with their own organisations. And we're able to work with the integrated care boards, with the NHS Cancer Alliances, and their programme, which is called Getting It Right First Time. They're having a head and neck cancer Getting It Right the First Time programme, which is again about trying to bring some of this data together with data about the treatment successes to try and improve some of the work on the early detection and treatment pathways as well. So, delighted to be able to bring this work to your attention today. We're very, very pleased that many people in the audience have been members of the steering group and have contributed to this work. So now the next step really is to try and realise some of these actions and see if we can prevent the worrying trends that we're seeing, the worrying geographic trends, and try and reverse those trends and prevent the disease for future patients and the public. Thank you very much.
Thank you, Professor Marshman. We'll entertain questions after Professor Lambert speaks as well, so now I'll introduce Professor Lambert.
Thank you, Arthur. Thanks, everyone. It's a real pleasure to be here today, and not just because I got the unexpected bonus of seeing my boss do the full Monty, which I don't think anyone was expecting. But I think, I think particularly I'm a lab scientist, and I think it's easy to lose sight of the personal stories and the impact of this disease when you're beavering away in the lab trying to do good work. So it's been wonderful to be here actually today, and it's great to see such a good turnout. Thanks to Chris and Sharon for inviting me. So I'm going to talk about something slightly different. I'm going to talk about a little bit of science. I'm not going to go into a huge amount of detail, but there's just a few emerging things that I'd like to talk to you about, and it fits well with the theme of neighbourhood, whether that's spelled with a U or without a U. So I'm going to start with just a little bit of introduction to what I'm talking about. So you may have seen images like this before. If you haven't, I'll very briefly explain. These are very thin slices of tissue, so either from a biopsy or a surgical resection, that can then be stained with dyes and looked at down a microscope. And what you look at there on the left is the healthy oral mucosa, so the lining of the mouth, and the purple dots essentially are where the cells are, and all our tissues are made up of cells. If you look at that image on the left, you can see there's very ordered structure there. If you look at the image on the right, which is taken from a tumour, that looks very disordered. So on the left, you've got everything in the right place, the right cells in the right places doing the right things, performing all the functions that they need to do. On the right, you've got all the wrong cells in the wrong places doing the wrong things. And that's what's happening in a tumour. And if you look at that, I like to show this diagram because it took me ages to draw it. But essentially what you look at there is healthy tissue is made up of different types of cells that do different jobs. In a tumour, you still have different types of cells, it's just they're often in the wrong place doing the wrong job. And we tend to think of cancer as cancer cells. A lot of biologists, the field of cancer research has been fixated on cancer cells for obvious reasons, because they're the drivers of the cancer. But actually, when you're looking at that image of that slice of tissue there, there's loads of different types of cells in there. That's not just tumour cells, it's not just cancer cells. There's loads of other types of cells which are illustrated on the right there, with the pink cells in the middle being the cancer cells, but all the other stuff around it being lots of different types of cells that don't carry the mutations that cancer cells carry. They are essentially normal cells, but they start to behave in abnormal ways when they're in the neighbourhood of a cancer, which we're coming back to neighbourhoods again. And I tried to think of an analogy for this in a geographical context, if it was what Zoe was talking about, and I thought about bad neighbourhoods within a city. So I looked at bad neighbourhoods within a city, I looked at Sheffield, turns out there's no bad neighbourhoods in Sheffield. So I had to go to Manchester, somewhere with bad neighbourhoods. Nothing against Manchester, but clearly it has some bad neighbourhoods. And here it's a comparison of crime rates in different boroughs within the city. And you can see there is the red areas are the high crime rates, the orange the less high crime, the green the low crime. In the middle there, you've got a clustering of areas of high crime. As you move out away from there, it's mainly green, low crime, but there's the odd neighbourhood that's orange or red, and these are our bad neighbours. So these are little pockets of bad behaviour out away from that central crime area, and there's probably connections between that central area where there's a concentrated area of crime, of bad behaviour, and these bad neighbourhoods, maybe even just the odd bad neighbours in some of these neighbourhoods as you move away from that central area of red there. And essentially, that's what's happening in a cancer. So you have the cancer cells, again, the pink cells, and then you have lots of other types of cells. You've got blood vessels, you've got immune cells, you might have bone cells, you might have fat cells, you might have muscle cells, all these different cell types around the tumour. They officially are normal, but they get corrupted by this area of high crime in the middle, and they start to misbehave. And a lot of these cells initially will try and stop the tumour growing and try and stop it spreading, but they become corrupted. And they will then help the tumour spread, grow and spread, but probably not all of them. So some of them are probably still the good guys, some of them are the bad guys. And there's a real challenge there to try and identify which are the good guys, which are the bad guys, and who's doing what within that tumour, because there's a lot going on here, there's a lot of different stuff here, a lot of complexity. And we started looking at one specific type of cell, one of those neighbours. We started looking at a cell called a fibroblast. I'm not going to test you on this at the end, but there's no other way I can term it other than a fibroblast. It's not a very catchy name. These are cells that normally keep tissue behaving properly, doing what it should, keeping things, doing the right things in the right places. You find a lot of them around tumours. Not every tumour, but most tumours, you find a lot of them. And you can stain them brown. You can see in this image here. These are your fibroblasts surrounding the blue bits, which are the cancer cells. These are the cancer cells, these are the surrounding fibroblasts. You can see in this section of a piece of tissue from a tumour, there's a lot of these fibroblasts. And when they're in a tumour, we call them cancer-associated fibroblasts, or for ease, I'll call them CAFs as the abbreviation. So these are the CAFs. And we've been looking at these CAFs for many years because they seem to do important things. And if you look at a whole group of sections like this from tumours, and you count the number of brown cells you've got for these CAFs, what you find is, I don't know where that black square's come from, but what you find is tumours that have a high number of these CAFs, for these ones here, they tend to behave quite aggressively, and people with those tumours do less well. Where you have a low number of these CAFs, and not many of them, these tumours seem to be less aggressive, and the patient does much better. The prognosis is much better. And it's actually one of, if not the, single highest predictors of outcome is the amount of these CAFs that are present. So they're not cancer cells, they don't contain the mutations, but they're doing something, presumably, to help this cancer grow and help it spread and help it behave more aggressively. So that means these then become good targets for new therapies. So most cancer therapies are targeted at the cancer cells, naturally. But there's a lot of interest growing in perhaps we can target some of these other cells. Because we know that these cells do things to help the cancer grow, to help it spread. We also know that they help the tumours resist therapy as well. And they seem to be involved in recurrences. So we think these are important cells to look at to try and develop new therapies against. And something that we also found was that in cancers that invade into bone, which has serious effects and also a significant impact on prognosis, when we looked at those tumours and we looked at where the cancer was going into the bone, so you can see here these blue areas, I keep trying not to blind out, sorry. These blue areas are areas of bone. That should be a piece of bone, but it's been broken up, it's been invaded by this tumour that's coming in from the left here, cancer cells. But all of this stuff that's invading into the bone, they're actually fibroblasts, they're calves. So it looks like the calves are sort of driving a path ahead of the cancer cells into the bone. So we thought this is something that we really need to try and target, because this may be a way to have a significant impact on the course of the disease and the impact of the disease. And no one had found that before. However, we quickly discovered that not all calves are the same. It's very likely that you've got good calves that are trying to do good things, you've got bad calves that are doing bad things, and various different types of bad things. So we needed to dig into what these cells actually are. And there's a whole load of emerging technology, which is really a revolution, where we can look in molecular detail, we can look at the genes that are switched on and off at an individual cell level. So we know what an individual cell is doing within this piece of tissue here. And that can tell us a lot about what those cells are doing. What is their function likely to be? Are they likely to be good guys? Are they likely to be bad guys? And this technology has really only emerged over the last 3 or 4 years to be used widely. We now have the technology in Sheffield. It's a very powerful tool. And what it allows us to do is look at exactly what each of these cells or an area of cells is doing, and whether that looks like a cell that we want to target or not. And you can draw a map of the cells based on which genes are switched on and which genes are switched off. And we can colour code those maps. If you look on the right here, this is normal healthy tissue. By looking at which genes are switched on and off, we can call out different groups of different types of cells. And you can see that these green dots here look like this top layer, the blue dots the layer underneath, the orange dots the layer under there. But you can't really see by eye the difference between the blue dots and the orange dots, but there is a difference. And that's what this technology can tell you. It can tell you that those cells are not like those cells. And you might want to target those with therapy, you might not want to target those. And if you look at a cancer, a slice of cancer tissue, you can see there's a whole world of complexity here. Lots of different coloured dots representing cells doing different things. And some groups of those cells might be the things that we want to target. So that's what we're trying to do. And in the context of cancers that are invading bone, what we're trying to do, these red guys, these are the bad guys. These are the bad fibroblasts. I think my aim is a bit out with this crosshairs. But what we're trying to do is blast away those bad guys, leave the good guys in yellow, and reduce the effects of those bad cells. In this case, on the invasion of bone, but there could be lots of other things that we can target as well. So it's pretty exciting times for this kind of technology. I really do think it's going to be a revolution in what we can understand about these cancers and how we can try and tackle them. One of the issues with this technology, however, is that to get this level of information, you need pieces of tissue. So you need some sort of surgical intervention to get that tissue. What would be really nice, and it wouldn't always be appropriate, but what would be really nice is if there was some way of knowing what was going on in that tissue without having to use surgery. If you could find something that the cells produce that told you what was going on in these different groups of cells. Now we know there are these different groups of cells, can we try and find them in a different way? So that we could work out what's going on in a tumour without having to resect the tumour or pieces off. And one area that we're really interested in at the moment is these little bubbles of information that cells produce called extracellular vesicles, or EV, but not that kind of EV. And all cells produce these things. They're kind of interesting looking things. This is looking down a microscope, a very high-powered electron microscope, and you can see these little bubble-like structures. These are our EVs that the cells are producing. They're weird and wonderful things, all sorts of different shapes, sizes, and so on. But the interesting thing is, with these, is they reflect the cell that they came from. So the DNA, other things that a cell produces are in these. So if we know we're looking for particular features of a cell, we might be able to find them in these EVs. And that's what we're trying to do. So without going into detail, they contain DNA, proteins, the sorts of things that we're interested in. And saliva is teeming with these things. So one thing that Stuart Hunt over there in particular has been leading is looking at, can we use saliva as a source of information, looking for these EVs to tell us about this complexity of the tumour without actually having to take out pieces of tissue and analyse them down the microscope. And in theory, this is highly suited to point-of-care tests. We all, I suspect, used COVID tests at some point. You spit in a tube, you put it on a thing. We have a grant funded at the moment to look to develop something exactly like that to detect these EVs. So it could be really simple. Most people don't mind providing saliva. In some cases it's difficult. It's not necessarily straightforward, but in most cases that's a possible and acceptable and painless thing. And it could allow us to detect these EVs derived that are coming from these cells that are our noisy neighbours. And that gives us the potential not just to diagnose, but to stratify risks, so to work out the prognosis, to look at responses to treatment, but particularly to provide highly individualised treatment based on this information that we had from analysing these tubes. So I think that's probably enough science. It's customary at the end of things like this, because it's not me personally in the lab who's been doing all these things. We talk about all the people who've contributed, but particularly all the patients who've been involved in informing these studies and consenting to provide samples. None of this can be done without you. So thank you very much. And it's expensive, and lots of places also need to give us money to do it, some of which are listed there. Okay, thank you very much.
Thank you, Professors Marshman and Lambert. I'd like to entertain some questions right now. I know Bill has the microphone, so questions for either speakers. Well, I have a question.
I've got.
Oh, do you have one?
I'm up here.
I can't
I've got
see the
a
lights.
question for Zoe. Thanks for the presentation, Zoe. As a geographer, I really appreciate the presentation with lots of maps in it. I think I can understand that. Are there any studies in other European countries that use the atlas to see whether there's an effect of that will look at the health system, and whether there's any link with the health system and the geographic incidence of cases of the cancer being reported, particularly to see if there's any sort of anything systemic about our health system that that leads us to have more sort of late diagnosis or something like that. Are there any studies that could indicate that?
Thank you. Thanks. The atlas was just England only. I mean, we did try and push for it to be wider than England and to have UK data, because I think that would have been useful to highlight some of the sort of differences across the devolved nations. There are lots of other European work on this and other European studies, but sometimes it's difficult to kind of generalise because of the different ways the health systems are set up. So if you think about other European countries have health insurance, perhaps have less publicly funded dental or medical care. So there isn't anything that's directly comparable to this, but I do agree it would be useful, because that would then perhaps help us to learn from other areas about sort of innovations that are used elsewhere that might help us to improve some of those rates, particularly, yes, as you say, about the early detection. So I'm not aware of anything, but perhaps there are others who are.
Yeah, I just wondered if it was those differences themselves that could explain some of the differences in the incidence.
Thank you.
Bill. Down in front.
question for Zoe. It's about how to impact change, really, because I've had the opportunity to be part of some discussions with the West Midlands Cancer Alliance Group, and they talk about issues around diagnosis, workforce gaps, those sort of things. So just wondering how you close the gap between the information you've got, which is very well presented, very clear, and practical issues they have on the ground in terms of turning it into action. I don't think there's any problem with people not wanting to improve things. It's a case of there's a huge gap there. It's funding, it's people, it's process, it's a system issue. How can you help them with that?
So our atlas focused very much on incidence and mortality in stage of diagnosis, and the options for action were about prevention of the cancer in the first place. But I think everybody on the steering group agreed that that's only part of the picture. For those people that have the disease, how can you make the treatment services better? Which is probably another atlas. And that's how we're trying to work with the cancer alliances. So that's a fairly newish organisation in its current way of working, and they've been really interested in this and have invested quite a lot in doing a head and neck cancer review and this Getting It Right First Time programme. So I think there's a growing recognition within the NHS Cancer Alliance world that head and neck cancer hasn't received as much attention as it should do, given how it's one of the most common cancers. It doesn't get the same sort of national recognition as some of the other cancers do, and perhaps some of that is to do with lack of data or perhaps lack of people advocating for it to be prioritised. So I think that the Getting It Right First Time programme, which we've been working with to try and provide some data, they've been visiting different cancer centres throughout the country as part of their work to try and look again where there's variation in cancer centres in the treatment they do. So to try and address that side of things. But you're right, there's the treatment side and there's the prevention side, and they both need to go hand in hand. And there's an enormous amount of work to be done, and considerable amounts of funding that are needed within the NHS, I would say.
Other questions? Dan, I have a question for you. The fibroblasts you described, so are they mutating or are they developing de novo? Are they something, I think you said to some extent, but they would be something you would target in addition to the cancer cells, or?
There's a bit of debate in the field. They're probably not mutated. That's the consensus, is they are essentially normal cells, but they have behavioural changes. It could be epigenetic.
Yeah.
I think the jury's still out. But they tend to have particular features that you could target.
Okay.
So whether that's a particular protein or something else about them that you could target. They're also potentially useful diagnostically because they tend to cause changes in the extracellular matrix, the glue that surrounds all the cells, which might be picked up by imaging, for example. So there's potentially a few uses for fibroblasts.
And you said it speaks for more of those are more aggressive cancer, did I understand you correctly?
That's what the data shows, yeah.
So they could be used prognostically, potentially?
Yes, absolutely.
Thanks. I have a question for Zoe also. You showed the map, if I remember correctly, and I know I have my head twisted, but of the northern part of the United Kingdom being darker, I think, in terms of incidence, and I may have missed this. Was there a breakdown between HPV positive and HPV negative in the various areas? Because I'm always thinking social determinants of health, which I've studied a lot in public health, and you think of people in more indigent areas also having a higher incidence of smoking, drinking, and non-HPV cancer. So I was curious what the data showed.
Yeah, so the data that we had was from the National Disease Registration Service. And it wasn't linked. So we can't say, we know that that person had cancer, but we aren't able to link it to what type of cancer they had or whether it was a HPV positive, for example. So, I mean, I know there are sort of other studies around the world that are trying to make those links between the data linkage, which would be amazing to be able to answer some of the questions. But ours was very much just the epidemiology data without it being patient data that could be linked to other factors.
Okay, thanks. Well, we have time for one more question, Phil, or?
Just the last one.
There we go.
Talking about the fibroblasts, I mean, that was quite interesting. Are there any linkages perhaps to the way that these cells don't act in a normal way for people who have underlying autoimmune disorders?
That's a really good question. So one thing we do know, and one thing that's increasingly recognised, is the crosstalk between fibroblasts and the immune system seems really important, and they're potentially quite important in the response to immunotherapies as well. In terms of autoimmunity, I don't think a huge amount is known, but I think it's a really good question, because you're probably starting on a different background there. Yeah.
That's a great question. I can tell you from a clinical experience, when patients have autoimmune disease and then we see them with head and neck cancer, it seems to be a very different entity. We really see, as you said, starting at a different baseline. Well, thank you all. I'd like to thank both speakers. That was a phenomenal discussion. I've certainly learned a lot, so thank you so much.
Richard, Hannah.
So thanks ever so much, and thanks very much for the invite today. It's been a great conference so far. I would like to introduce our next speaker, Richard Andrews, who's here today to tell us about his story following neck cancer diagnosis in 2018. And following treatment, he began to undertake lots of running, triathlons in particular, but ultramarathons and duathlons, and he became the first laryngectomy to undertake a triathlon using a specially designed snorkel. So we're very fortunate to have Richard here today to tell us his story. So thank you very much, Richard, and really looking forward to your presentation.
Thank you very much. I think there's a video to play, I think. But while I'm trying to find it, I'll talk for a little bit. Thank you for inviting me here today. I was diagnosed in 2018 with laryngeal cancer and underwent 6 weeks of radiotherapy, which basically, as the patients here know, knocks the living shit out of you. I 3 months later, I started exercising to recover. Really what I'm trying to say is, from the patient point of view, I think the 4 most important things are your family, the support, for me exercise, getting out and trying to recover, and also having goals to aim for. And what I did, I never ran before, but I started running, started exercising, and it just continued from there. With regards to my family, they're not actually here today because they're in Australia, so watching take that. Nicer weather. But my family have been keen. My wife's a nurse, so she's been my primary carer. After having my radiotherapy 3 months later, I was re-diagnosed and it had come back on my right vocal cord. So the only option at that stage was to have a laryngectomy. To me, it's another hurdle my wife was always there at my side, so it made it a lot easier. And my sons and daughter have always been there to support me. 3 months after I had the laryngectomy, I did the Cardiff Half Marathon. And from there it just snowballed, and I just kept on setting myself new challenges, new goals to push forward and to basically get better. And this is some of the things I do. So you've got the swimming. So there was a special snorkel developed down in Exeter by the staff down in Exeter Hospital. And they did it off their own back. There was no government funding. It was a couple of speech and language therapists that found it and set up the system. And I was lucky I was the last person to actually get access to the snorkel. So from there I decided to just do a little bit more than running, so I started cycling and started swimming as well. And through that I was able to get better a lot quicker and also just keep on pushing through. Unfortunately, the YouTube video, a friend of mine did it for a dissertation, so it basically explains it far better than I am now. I think key for all of us that have suffered from cancer is the support and the network of groups or clubs so you can become members. It actually helps you and pushes you forward. The problem with a laryngectomy is you get very anxious of social situations. You think people won't be able to hear you speak. You can't hear them. So it's very, very difficult. So the supportive group, the specialist nurses, the speech and language therapists are key. And without them I'd be absolutely knackered. Because they look after me all the time. All I have to do is ring up and they'll sort out a new valve. And the consultants as well. Although some of them are a bit of a pain, they're alright. And they've got me back on track. I've got a massive scar now. But this is a dry club I'm a member of. And they've been very, very supportive. If ever I have an issue, they're always there to help. And also now I try and mentor people that are having laryngectomies so that I can actually feed onto them, because one of the problems with this is that there's no information beforehand. You're going to have a laryngectomy, you're going to have radiotherapy, but people don't tell you what it actually involves. And I'm not being funny, but the doctors haven't had radiotherapy. They don't know what it's like. It is quite possibly the worst thing you'll ever experience. So there needs to be groups there like the Swallows that are there to support people. And that's where it comes from our point of view, from the patients. There needs to be more support, more information given at the very start, so we know what to do. I haven't got a lot more to say, I'm afraid, but I think there's going to be a few questions, so if anybody's got any questions, please help me out so I don't have to keep on talking. Thank you very much.
Thank you very much, Richard. That was really interesting, and your YouTube video is brilliant. It's really, really inspiring.
I thought it was as well.
Great. Has anyone got any questions?
Please.
Oh, we've got one at the front there.
That was an amazing story. I'm a runner, but I'm working on a half marathon, nothing like you. So when you do, with this group that you've got now, are they all laryngectomy survivors, or is this a general running group that a triathlon group that you're doing?
It's a general running group. Most of the people that I've seen that have got laryngectomies don't actually want to run and don't actually want to swim. But one of the things with the swimming, it makes you normal again. You're able to do what normal people can do. I can't eat normal food, I can't taste food. So anything that makes me feel normal again is great. And that's what the swimming, the running, the cycling does. And that's what needs to be encouraged. And that's what the doctors, the nurses should say. I was told at the very start, you won't be able to run very far, you won't be able to cycle. And you won't be able to swim, you won't be able to do anything basically. You're just going to have to live with what you've got. Well, I'm sorry, but that's wrong. You can do whatever you want to do, you've just got to go out and do it. And have the support of the people that want to do it with you. So, I hope that answers that.
Fabulous, thank you.
Hello, it's just a very
Hello.
hi, very quick question. That's really interesting and inspirational, thanks. I'm over here, sorry. All I wanted to know was just what the title is for the YouTube video, if we can't see it now, if we can access it later.
Beyond triathlon. Beyond boundaries.
Yeah, Beyond Boundaries Triathlon.
Okay,
There you go.
thank you. Thanks.
We've got quite a lot back.
Thank God for that.
Hi. You're the first
fellow.
Yeah, another one. Actually, you're the first person I've spoken to ever since I had my operation. So I'm pleased to meet you.
Pleased to meet you too.
I had two questions. Firstly, about this snorkel. Because I've looked at this snorkel on the internet. I used to be a very keen swimmer. But the idea of it fills me with the fear of death. The water goes down the hole and you're dead. So I wonder if you could say a few words about how you learned to use a snorkel. And then the other question really is mentioned about social isolation. And I wonder, do you find it more challenging to speak for extended periods? Do you try not to speak in social occasions, if you see what I mean?
Yeah, with regards to the snorkel, it basically you have a lesson for about half an hour, which trains you how to use it. You have to put your own trachea tube in, so it's some horrible crap, it's the only thing I can taste when I put that in. So you spray that in, put a trachea tube in, blow it up, and then you attach a snorkel to it. Luckily mine has never leaked. Although what they say is you're limited to an hour in the water with the trachea tube in. Well, I've done an hour and a half swimming a lake with the trachea tube in and it hasn't leaked. So it's perfectly safe. I hope. With regards to the social isolation, I avoid social meetings. There's a president's dinner which I've been very kindly invited to tonight. But I hate them because people can't understand what I'm saying. So I try shouting and then I play with the bloody bass blade off my face. So then I can't talk anyway. So I try and avoid them, and eating wise, I have trouble eating solid food. So because of the food pipe shrinks anyway, so I try and avoid them if I can. Apart from the running club. But one of my side effects with having a laryngectomy, I get I've ended up like having swearing Tourette's, so I end up swearing. So it's probably a good idea to keep me away from situations. We'll talk later as well.
Thank you so much for that really inspirational talk. one of the dietitians at Torbay Hospital. I just wondered how you manage with your eating difficulties with carb loading when you're doing so much exercise. Do you have tips that we could pass on to people who struggle with things like bread and potatoes?
It's a secret. No, basically what I have now is I eat baby rice, which is mixed with hot water, which is basically 87% of that is carbs. So I did a 40-mile ultramarathon in June, and you basically break every 8 miles at a checkpoint. So I had a bowl of baby rice at every checkpoint. But what I would advise is never take your wife on to run the checkpoints with you, because you end up nearly getting divorced. Not a very good idea. But also I take gels, and I use an electrolyte mix of, trying to think of the name of it. It'll come back to me. But yeah, baby rice is the best. And pastrum. But it doesn't go down very well with me, so I don't take that. Does that answer it?
Yes, thank you very much.
And if you need any details, let me know.
Thank you.
We have another question here as well.
Hello, thank you again for your talk. I'd love to hear that you go and meet people before they have their laryngectomies. We always offer our patients to meet someone that's had a laryngectomy before their surgery. What sort of questions do you find that you're asked the most when you meet someone?
I think people tend to be worried about how it's going to affect ongoing. Are they going to be able to eat? Are they going to be able to talk? And how they're going to be able to communicate in the future? And they're the things that... And also time scales. People tend not to be upfront about how long it will take to have a speaking valve put in if you've already had radiotherapy. With me, I can talk for 3 months, which is a blessing for some, but for me it was a nightmare. So it's being honest with people as well and trying to explain to them that you're going to have patience. Patience is the biggest thing. If you have the operation, don't expect to be able to talk the next day. I mean, it's not going to happen. And it's just getting people to understand as well. I can see the guys from Atos. I use Atos. Base plates and valves. And they're superb, but you need to know how to use them and be shown how to use them from a practical point of view. Speech and language therapists and the specialist nurses are absolutely fantastic. But they haven't got a laryngectomy. So, with all the best will in the world, they don't know how to put it on properly so that it doesn't keep on blowing off. Otherwise, you talk for about 5 minutes and then that's it. So that's the support that's needed. Difficult to give, but laryngectomy patients should be asked down. So have a buddy system so that you buddy up with another laryngectomy that's similar sense of humour maybe, similar interests. So, hope that helps.
Thank you.
I've got a question, Richard.
Go away.
Two-part question. One,
Hang on. Let the audience hear, and don't take any more than 30 seconds, Chris.
so it's a two-part question, Richard. Who does your emails when you're sending them? You or your daughter?
Me, unfortunately, I'm not very good at emails.
So do you know how to do attachments?
Not very well, no.
Okay. So your presentation come, but your video didn't, because we just checked it. So thanks for blaming it me, but I just, if you put it on the screen afterwards, I was going to put it up on the screen.
Got it.
No, I was going to put your email up showing that you but another serious question is, last year's conference, we both spoke afterwards about a wing walk. I hate heights. I don't even go up that stage without getting frightened.
I thought we said a parachute jump.
No, on your bike. So, no, wing walk. You said a wing walk. You said you would walk on the end of a wing of a plane, preferably a jumbo jet. But and I said, if you do it, I would do it. We need to plan it for 2025.
Don't have a problem.
But I have to say, guys, this guy is such an inspirational guy. He does everything he shouldn't do. So do not, Sam, do not buddy him up with another laryngectomy patient unless they have got a sixth sense of humour and is daring is what this guy is. But thanks, Richard. But I just wanted to mention that. So thank you.
You're very welcome.
I think we've got one more question. One more question over on the left. Perfect.
Hiya. Just wanted to ask, so as a therapy radiographer myself and my colleagues, it's heartbreaking to hear you say that radiotherapy is one of the kind of worst things. It's obviously it's horrible treatments. What could we do as, you know, caregivers, whatever, to make that better for future people going through similar things? You know, it's really hard to hear you say that it's a horrible thing to go through, which it is. It's, you know, and we want to know what we can do to make that better.
Don't hold back with them.
Yeah, be honest, please. Like, it's not personal, you know, against us or therapy radiographers.
No.
You know, please be honest.
The radiographers are absolutely fantastic. In Hereford, they were brilliant. There isn't a lot you can do, unfortunately. It's just really shitty.
It's the nature of the treatment, isn't it? Yeah.
30 days, 5 days a week with the weekends off. First 4 weeks are a breeze. The next 2 weeks are a nightmare. The 3 weeks after that are even worse. There's not a lot you can do. And you obviously can't say to patients, I'm sorry, but it's going to be really. You can't tell the truth. Because you wouldn't have anybody coming in for radiotherapy. I mean, you wouldn't.
But would you have preferred the truth, to know that that was coming?
Yeah.
That's
But all different.
Yeah, good to know.
Most people don't want to know. I mean, the mouth has not been out. It's not nice. But the radiographers are great. And all the health professionals we deal with, I found, I can only talk from me, have been fantastic. Right across the board. But, no.
Just a shit treatment.
Yeah, when it is, then we might be honest. Thank you. Pardon?
That'd be well.
That'd be nice. I mean, I wish they'd just taken it out in the first place rather than give me the radiotherapy first and then say, "I'm sorry, it's back again." You said that'd work.
Yeah, but then we wouldn't have you on stage, like this.
Well, no, there is that. Did you have a question?
You. I did, yeah. Does anyone else have any other questions? I'll ask one more question before we go. You're great. I was just thinking, your story is really inspirational, and this is your next challenge, isn't it, that you were telling me about earlier?
Yeah.
Your challenge for next year. What are you hoping to do next year?
I'm doing Brecon to Cardiff, which is 43 miles in February.
The ultramarathon.
Ultramarathon, and then there's basically one called the Pegasus Slam, which is 6 ultras in 6 months.
That's
So
6
that'll
ultras
be-
in 6 months.
Yeah, 260 miles.
Okay.
And it's in Wales, so it's a bit of climbing.
Just a bit of climbing. No, in Wales is a bit of climbing.
Chris,
Not as much as Sheffield. But
when he tells us where next year's conference is, I'll run to it.
you run to yeah. And then you'll do the wing walk.
So can you make it Hereford?
And do you think there should be greater research into the effects of exercise during recovery from head and neck cancer?
Yeah, I mean, if you look at America and you look at Australia, there's lots of evidence being proven that exercise helps.
Yeah.
And I think all the patients know that it's the mental side of it as well that screws you up really badly. And the running, for me, I enjoy running. I enjoy the process of running. I don't run because I have to. I run because I enjoy it. And it clears your mind.
Yeah.
talking earlier.
Good. Yeah. I started running this year and I found exactly the same.
Swimming is the same. So it's, you don't have to go out and run, you don't have to go out and cycle, go out and walk. But just
doing
something to take your mind somewhere else. And that's what saved me, otherwise I'd be in a box by now.
Thank you so much for sharing your story.
You're very welcome.
Really. Oh, perfect. So I've just, Chris just let me know we're going to put Rich's film on tomorrow, so you'll be able to see that tomorrow. But you can search for it on YouTube as well. Thank you ever so much. Just a quick reminder for any health professionals that want CPD, if you come along to the University of Sheffield stand and give your name, email address, then we can send out CPD certificates. Thank you ever so much to Richard for that brilliant session. And we've got coffee now until 4 o'clock. So enjoy that. So thank you ever so much.
Right, good afternoon everybody. My name's Emma Hallam and I'm a therapeutic radiographer who runs a late effects service in Nottingham, and it's a great pleasure for me this afternoon to chair this session on a topic that is very close to my own heart. So first of all we have Kerry Robertson, who is the clinical lead speech and language therapist for head and neck oncology at Sheffield Teaching Hospitals. She was lead author of the Royal College of Speech and Language Head and Neck Cancer Guidance Laryngectomy Position Paper and Laryngectomy Competency Framework published in December 23. Kerry will discuss the role of speech and language therapy in rehabilitation of speech, swallowing, during and following head and neck cancer treatment. Thank you.
Thanks Emma for the introduction. So I'm Kerry, I work here at Sheffield Teaching Hospitals and I'm a speech and language therapist. So as survival rates increase for head and neck cancer, we will actually see more people living with the side effects of head and neck cancer treatment impacting on their swallow and their communication. And a recent study at the Royal Marsden Hospital used a patient concerns inventory questionnaire at their post-treatment follow-ups and found that the 4 or 5 main concerns that patients had were dry mouth, swallowing, fear of recurrence, head and neck pain, and problems with chewing. And 4 out of these 5 items do relate to people's swallowing, so it is a major concern for people after treatment. 50% of people are still experiencing symptoms of swallowing problems or dysphagia 6 months after treatment. And these can include things like taste changes, dry mouth, problems with the risk of aspiration, having to have different fluids or different modified diets, and it being effortful to swallow. And let's not forget the impact on quality of life and social eating situations. So speech and language therapists support people across the head and neck cancer pathway, and we get involved with seeing people pre-treatment. We'll offer information and advice on how the proposed treatments are likely to impact their voice, their swallowing, their communication. And where people are going to be having major surgery such as total laryngectomy or total glossectomy, we believe it's really important to arrange for them to meet a buddy, to meet someone who's been through the treatment and can talk to them about how things are going to change with their communication, what options might be available to them to hear someone using a voice prosthesis to speak with, or to be shown how they care for their laryngectomy stoma and the filters that they use. It's really important. And we may also offer voice banking for these patients so that they're able to record their own voice before their voice is significantly affected by treatment, and then their voice can be used for things like text-to-speech apps. So it's their voice pre-treatment that they have recorded and stored to use as they want to afterwards. We also offer pre-treatment exercises. We're trying to strengthen the swallow or the voice. We're trying to build up the muscles that might be affected by treatment, particularly pre-radiotherapy, we're wanting to strengthen and prevent fibrosis of the muscles. And where someone has already got dysphagia, problem with swallowing, then we will give them exercises to try and strengthen and improve the swallow before they start treatment. We'll also carry out swallowing assessments, so people may already have a swallowing problem before they start treatment, and we want to get them onto the safest recommendations for them. We want them to be able to swallow as safely as possible, and we want them to be as well as possible for their treatment, so that they've got their optimum nutrition and the best chest status that they can have going into treatment, so that they're going to have better outcomes following treatment. During treatment, speech and language therapists have got a specific role with tracheostomy weaning. So we see people on the wards after surgery, and we will assess the swallow, we'll look at the secretion management, we'll look at their airway. Are they able to cough and clear? Are they going to be ready to have their tracheostomy removed? And if not, can we facilitate them being able to voice in the meantime, or being able to swallow? We also have a very specific role with laryngectomy voice restoration following surgery, and introducing items such as filters to filter and moisten the air that's being breathed in for neck breathers, and introducing the right types of equipment at the right stages. So that's quite a specific role to speech therapy. And we also will carry out the first swallowing assessments after surgery, when someone starts to resume oral intake. And during radiotherapy, we'll do swallowing assessments for people who are struggling with their swallowing, to try and get them to keep swallowing if they can on something that's safe and manageable for them. We also help people to adjust and deal with the new symptoms as a result of the treatment. And then post-treatment, we carry on offering support. So we'll carry on doing swallowing and voice assessments and rehab, and we might introduce some therapy devices to augment the exercises that we are giving to patients. We'll continue to support and help people to adjust to the side effects of treatment, and we might introduce maintenance programs to help them to maintain the swallow function that they have long term. And we accept re-referrals for people as well, sometimes many years after their treatment has ended, to help them with their swallowing, their voice, their communication. This is a word cloud that we generated from a service evaluation that we did here in Sheffield. We introduced a new service for all head and neck cancer patients attending Western Park Hospital up the road. And previously it was only the Sheffield patients that we were able to see on treatment, which wasn't fair. So we got a new service going so that everyone had an on-treatment speech therapy review. We carried out swallowing measures, we offered support with side effects, we linked in with other healthcare professionals as needed. And patients really valued the reassurance and the encouragement that was given. They liked the reminders to do their exercises, and they also benefited in quite a significant way with their oral intake. So we had quite a few people who were nil by mouth actually being able to resume oral intake again on treatment, despite them being mid-radiotherapy, and people who were on fluids only being able to have diet again. Or people who were on pureed diet actually being able to then manage regular diet even though they're on treatment. So this is really significant. We've kept this service going, and we believe that that's going to help them to have better outcomes post-treatment, because if you can keep swallowing textured food during your treatment, you're using those muscles, you're using your swallow function, and hopefully avoiding stricture longer term. Part of our toolkit is instrumental assessment. There's a little typo on here, so it should be fibre optic endoscopic evaluation of swallowing, or FEES. So we use a nose endoscope up someone's nose, and then we'll give them different coloured foods and fluids so we can see where it's going. And we get an image where we can see the vocal cords here, and we can also see secretions.
We can assess swallow safety because we can see when aspiration is occurring before and after the swallow. And we can look at swallow efficiency. So what's the movement of the structures like? What's the pressure for swallowing? Where's the location of residue? Does the residue penetrate so within the laryngeal vestibule? Is it aspirated and passing into the trachea and going below the vocal cords? And we can also, on a FEES assessment, look at vocal cord function because we can see the vocal cords. We can see the protection of the airway when someone's swallowing. And we use standardised rating scales when we do a FEES assessment so that we can repeat it again at a later date and we can measure progress in rehab and encourage people and show that hopefully things are getting better or things are staying the same and that we're now looking at a maintenance programme. FEES can also be used as a biofeedback tool. So whilst the camera's there, we can move the screen around so that the patient can see where the residue is, and then we can get them to trial a technique and say, okay, can you see the residue that's there? Can you just try doing this technique and squeezing as hard as you can, see if that's going to be more effective in moving the residue. So that can sometimes be really useful for people to actually see live as they're doing their swallowing strategies. And another instrumental tool that we use is video fluoroscopy, which is a video x-ray of the swallow. And this allows us to assess the oropharyngeal stages of the swallow. With this type of assessment, we can quantify the amount of aspiration, which is something we can't do on the FEES assessment. And you are actually able to see aspiration during the swallow, which you can't see on FEES because there's a whiteout as people swallow and all the structures squeeze. There should be a whiteout on FEES, so we miss the point of the swallow during an effective swallow. However, there is radiation exposure of having a video x-ray, so that does limit how frequently we can reassess someone with a video fluoroscopy. And we also use video fluoroscopy for laryngectomy voice problem solving, so where someone's finding it difficult to voice, we can see where the voice prosthesis is, we can see how it moves as someone swallows or attempts to voice, and then we can also look at the vibratory segment, and it can help us to diagnose spasm or stricture and then help someone with their voicing as well. And again, we use standardised rating scales so that we can repeat the video fluoroscopy and we can compare it to previous video fluoroscopies. So speech and language therapists use various compensatory techniques to try and help someone with their swallowing. We may make really specific recommendations about diet and fluid modifications, and we use the International Dysphagia Diet Standardisation Initiative. There's a stall about IDSI behind that you can have a look at. So it's a framework that goes from 0 being thin fluids to regular diet, which is 7, and then we've got these modified thickened fluids here, modified diet here. So sometimes we will recommend thickened fluids for someone because the slower moving fluids may help to reduce aspiration for them. So it means their chest status is improved, and it just cuts down the risk of aspiration. The fluid moves slower. If they've got a delayed swallow, it might just give them more time to swallow before that fluid is aspirated. But you can't generalise that to everyone because some individuals could become quite dehydrated if they're not tolerating thickened fluids very well, not liking them. And also they can increase the residue within the throat. And then I've seen this recently actually on a FEES where the thickened fluids really didn't help because they were thicker, they hung around, and then they just made their way into the airway afterwards, and actually the person was better with the thinner fluids. There is something called the free water protocol, which is considered for patients sometimes. So patients may continue to swallow water only, accepting that that is likely to go down the wrong way and be aspirated based on assessments we've done. But it's for quality of life. It's for their mouth care. It's to maintain the swallow function as well, to keep them using the swallowing. They might find it a lot easier to swallow and clear secretions with a little bit of water than it is to try and just swallow saliva alone. So we bring together the assessments we've done, the opinion of the person we've assessed and their advocates, and we discuss it as an MDT. So this is a decision that would involve the medics as well, and knowing that this person will need regular mouth care, that's really important as a part of this protocol, and ongoing reviews of their chest status to see how they are managing. And then we might recommend postural adjustments as well to help someone with their swallow. So we might get them to put their chin down as they swallow. That might help to direct the bolus to the back and to prevent aspiration. Or we might try a head turn to a weaker side to redirect the bolus down the stronger side. However, you can't generalise these strategies to everyone as being helpful, and our recommendations are made on an individual basis. Some of our swallowing exercises are listed here. So we have the Shakir exercise. So that's lying down and lifting the head up and working hopefully the posterior pharyngeal wall, which comes forward to meet the base of tongue for swallowing. There's the sitar exercise, or chin tuck against resistance. It's being used here and working the supraglottic muscles to hopefully help them with laryngeal elevation for the swallow. The Mendelssohn maneuver, where you start to swallow and hold your voice box high, really work on the laryngeal elevation. Effortful swallow, so squeezing hard as you swallow. And the Masako, tongue tip between the teeth, keeping it there and swallowing. We might do supraglottic swallow, which involves holding the breath to try and close the airway swallowing. Pitch glides, which work on laryngeal tilt. And of course mouth opening exercises as well, which is important for chewing. And oral hygiene as well, being able to clean teeth. And here's some of the latest devices that we are using in addition to our swallowing exercises. So Sam's going to talk in a bit about her experience of using the Iowa Oral Performance Instrument, or IOP, which is a pressurized bulb that's placed in the mouth and squeezed against with a biofeedback tool to see how hard you're squeezing. The Therabite device, which is used for mouth opening, and I've seen that we have an expert patient in the room using that device. Expiratory muscle strength training, which we use here at Sheffield. So some research has shown that 8 weeks of EMST can significantly improve maximum expiratory pressure for head and neck cancer patients and can reduce the risk of aspiration. There's some good research coming out. Neuromuscular electrical stimulation, here being used with a device to work on the sitar exercises, and another device here. And a new emerging area is the use of ultrasound for swallowing assessment. And AI is apparently being used for swallowing screening as well. So there's new research coming out, and we need to develop these areas of research for head and neck cancer as well. So recently the Royal College of Speech and Language Therapists updated the head and neck cancer guidance, which included a laryngectomy competency framework. So this is for SLTs who are developing their skills in working with people with laryngectomy. And what we've done with this guidance is make sure that we don't just talk about SBR, so voice prosthesis, but we talk about all methods of communication after laryngectomy, and make sure that SLTs are confident in presenting and teaching people to use electrolarynxes, to use esophageal voice, to use gesture, to use things, anything that's going to work for them, and not just use one method, to be able to use more than one method of communication. And as part of this resource update for the Royal College of Speech Therapists, there's also online pages of resources with videos, resources for patients, family members, healthcare professionals, and that's the QR code up here for those resources. And the Swallows charity, I want to thank them for reviewing all of those updates and helping us to make adjustments. So things like, rather than saying laryngectomies, we said people with laryngectomy in what we wrote. So thank you. That feedback was really valuable. And I've also put a little plug at the bottom here for the By Your Side patient app, which was developed here in Sheffield. People going through head and neck cancer treatment, and it provides resources that people can use through an app, and there's the QR code down here for that as well. Thank you for listening, and hopefully that's given you an overview of what the SLT role is in rehabilitation for head and neck cancer. And yeah, hopefully you've got some links to some resources as well that you might want to have a look at. Thank you.
We'll take questions after everyone's spoken. So next up we've got Carol Keane, a consultant physiotherapist and clinical lead across South Yorkshire for Active Together. This is a prehabilitation and rehabilitation service for patients with cancer. Today Carol will present the service along with explaining what they have been doing in Sheffield to expand prehab to people being treated for head and neck cancer.
Thank you, Emma. So, as Emma said, I work in prehabilitation and rehabilitation in patients with cancer. And what we mean by that, by prehabilitation, is about trying to prepare patients well for the treatment that they're about to go through. We know that cancer treatments can have a negative effect on people's health and their well-being. By getting people as fit and well as we can before they start their cancer treatment, we don't necessarily get rid of those negative effects that you're going to experience as you go through your treatment, but it does mean that you start from a better position, which means that when you get to the end of your treatment, you're in a better position to go forward. And then by offering rehabilitation to patients, what we can do is improve their function, improve their well-being, improve aspects of their health, getting many patients back to where they were and as well as they were before they started their treatment, and in our experience, getting some patients back to being even better than they were before they went through their cancer treatment. Prehab and rehab in cancer is a relatively new field. The first guidance, the first documentation that came out in it was some evidence that came from Macmillan in 2018-2019, and that's being reviewed and rewritten at the moment. And at the time, it talked about the evidence around prehab and rehab in head and neck was very minimal. There wasn't really very much there. However, there was good evidence about prehab and rehab in other tumour groups. There was stronger evidence in colorectal, in lung cancers, bowel cancers, and so on. And so that, in the early stages, was where prehab has grown. So the first sites and services that were set up, and the Active Together service, when we first started, we started with those tumour groups where the evidence was there already, where the evidence was stronger. Much easier to generate a case for some funding to do something if there's some evidence that suggests that it might work already. But we were aware that that felt a bit inequitable. So some patients are getting the benefit of this and some aren't. In 2000, just this year, there's been new guidance around management of head and neck patients, and within that there was discussion about prehabilitation and rehabilitation, and that's documented within this report. And it talks about the fact that still the evidence around prehab and rehab in cancer in head and neck is minimal, and it isn't there. There is a better and growing body of evidence, however, about the benefits of prehab in other tumour groups, like bowel, esophageal cancers, lung cancers, and so on. And there is also clear evidence of treatment burden being particularly and significantly high in patients with head and neck. So although the direct evidence isn't there, although the evidence directly linking the benefits of prehab in head and neck patients isn't there, by pulling together those other threads, by saying, well, it works in lots of other patient groups, and there's a lot of need in this group, the recommendation, therefore, from this report is that that prehab should be something we should be thinking about in this patient group. So they've given some general guidance and advice, and that's what we've been then following. I mean, in fact, we were doing it a little bit beforehand as well, but that's the approach that we've been taking here in Sheffield with our Active Together service. Oh, so these recommendations have come up in quite small font, haven't they? So what they suggest is that there should be a general, so the recommendations from this, I'll let you read, but it talks about an MDT approach, it talks about a mix of exercise, about psychological well-being and screening, about functional assessment, about lifestyle adjustment, about diet support, and about access to speech therapy. So saying that people going through their cancer pathway and their cancer journey as early as they can, before their treatment starts, should have access to all of these services so that they can get as fit and well as they can going into their treatment, and then access to rehabilitation afterwards. So Active Together is a prehab and rehab service that we've been running here in Sheffield since 2022. We're funded by Yorkshire Cancer Research. And as I said, we started working with patients with different tumour groups, with bowel cancer, with lung cancer. What we do is we work in a prehabilitation phase where we see patients as soon as we can, as early as we can, after they've been diagnosed and after the decision about their treatment has been made. And we support them then to get as fit and well as they can between that point in time and their treatment starting. We then continue to support patients through treatment, and that's varied and it's individualised because some patients might have surgery, some patients might have chemotherapy and then surgery and then more chemotherapy, some patients might have radiotherapy, and so the support through treatment is different depending on the patient's cancer treatment. We also then offer everyone 3 months of rehabilitation once they've finished all of their treatments to support them to help to recover afterwards. And then we have a final, what we call the supportive phase, which is also really, really important, where we take a much more hands-off approach to the patients, but what we're encouraging them to do and what we're supporting them to do is to take all of the things that they've learned from us, to take the lifestyle and behaviour changes that they've adopted while they're with us, and to carry on doing those and managing those independently. So if they've been exercising with us and they've been coming to us and exercising regularly through that supportive phase, we're keen to help them to pick up exercise in different settings, going to the gym, going to tennis, doing some walking with their family and so on. So this is a continuation. This isn't an intervention, it's a continuation that goes on beyond their time with us. So our version of prehabilitation is multimodal. We offer exercise and physical activity to patients. We offer nutritional support and we offer psychological wellbeing support. And I think it's hopefully obvious that those go, they're interlinked. They go really, really well together. You can't exercise effectively if you're not eating well. If your mood is low, you're not going to prepare yourself a nourishing meal. If you're not eating properly, it can cause huge anxiety and worry. And so we have to get all of these things right and to get one of them right. And in Sheffield, we're very fortunate, actually, you know, we set up Active Together in 2022, but the speech therapists were ahead of us, and so our speech therapists in Sheffield have been seeing patients in that prehabilitation window long before we existed. And again, that's a really important component of all of this as well. So we assess everyone's needs. We don't offer everybody the same thing. It's an individualised and tailored type of care. So, you know, somebody might have particular issues with their diet and nutrition and really, really struggling with their eating. Other people might be doing absolutely fine. So we identify what level of need people have and tailor the support to suit them. We offer our support in lots of different ways. We want to make it as easy as we can for people to access the service. So we offer exercise groups. We can see people one-to-one if they need to. We run out of a range of different venues across the city. We're in different leisure centres, and we try to focus our time in those areas of the city where there is highest levels of deprivation, so it's easier for people to get to us. We offer online classes. People can do a home exercise programme. People can watch an exercise video. So we're trying to make it as mixed and varied as we can to make it easy for people to come to us. We embed behaviour change in what we do. We know and understand that it isn't easy, and we know this from our own lives. It isn't easy to exercise more, eat well, live well. It's not as easy as me telling you to do that, is it? Otherwise, life would be a whole lot different. And so we embed a lot of behaviour change approaches in what we do to support patients to make the decisions and make the choices that we know, and to give them the skills to keep doing that afterwards. And we have a real focus on the patient. We ask the question, what matters to you? What do you need? So that we can tailor the service to meet their functional needs and goals. So we've been growing the service over the last few years. We've been doing that by introducing new tumour groups along the way and bringing in different tumour sites. We see patients where, at the moment, from our funding arrangement, we see patients where, at the outset, their treatment intent is curative. We see people whose cancer treatment is of any nature, surgical or radiotherapy or radical chemotherapy. And at the moment, we see all of those patients who are being treated in Sheffield. Everybody who is having their treatment in Sheffield, regardless of where they live, is welcome to join Active Together. And so, based on all of our work in Active Together, and based on the evidence, and based on the guidelines, and based on many conversations with the MDT in head and neck, about 6 months ago, we started a small pilot to see how it would look if we started to bring head and neck patients into the Active Together service. So we started with seeing maybe some of the more straightforward patients, some of the patients with the lower levels of complexity from a head and neck point of view. We felt that those would be the easiest patients for us to start with. So what I'm just going to go through in my next slides is just the first sort of, I think I've got 11 patients, the first 11 patients who we've seen come into the service, and give you a little of an idea of some of the things that we've been doing with them. I think interestingly, we have had about an 80% uptake from the patients that we've seen, and that's pretty much the same as it is across all of our tumour groups. So some patients do choose not to take part in Active Together. The reasons they mostly give us for declining is because they've got other commitments. So because they've got, maybe they're still working and before they start their treatment, maybe they've got caring responsibilities or other things that take up their time. Often it is a busy time for them and they have other appointments, and they feel that can be a bit overwhelming and difficult. And so we are mindful of that, and we do try and fit in with them as much as we can. And some patients just don't really feel ready to take that step with us, so they might say, it's just too soon, can you get back to me, or I'd like to think about this a bit later. So I talked about that needs assessment earlier. So for the patients that we've seen so far, I've broken them down to see what level of need we were finding in them. So red represents those patients with the most complex needs, who are specialist in their need. Purple are the sort of the middle band of patients. And green are those patients with lowest levels of need. And we look at need across their physical activity, across their nutritional need, and across their psychological need. And so what we've seen with our patients so far through the head and neck service is that from a physical point of view, most people have been universal, so doing quite well from a physical point of view, or in that targeted zone. Patients with the highest, where the need has been greatest, is in the nutritional aspect, and I guess that sort of maybe fits with what you might expect with this patient group. So we've seen a higher number of patients with specialist levels of nutritional need. And from a psychological point of view, again, at the point that they've come into us and their early points of their referral, we've seen patients with either universal or targeted needs. So the main area of focus has been dietetic, and patients in the other domains have been at the moderate to lower end of need. And this is at the point of referral before they start treatment. We do exercise testing on all of our patients. We use what we call a 6-minute walk test. So we ask them to walk up and down for 6 minutes and we see how far they go, and that's a way of us measuring how fit they are. And some patients, in some sites, we don't have the space to do that, so we ask them to do a test where they stand up and sit down for a minute, and those gives us a gauge of our exercise. And really what we found is mostly those patients who've come into us who we've got this data for are pretty fit, are doing quite well on their walking test. So whether that's a feature of this group of patients and those patients who are going forward for curative treatment, or whether it's a feature of the patients who people are choosing to refer into us, and we will take everybody, but people do kind of think, oh, they'll do well with rehab or things like that, remains to be seen. But actually these patients aren't struggling at this point too much from a physical point of view. So of the patients that we've been seeing, those who have been in prehab, and while they've been in prehab, they've had a bit of a mix of inputs. So some of them have had one-to-one exercise, but others have joined our group classes, others have taken a home exercise program and exercised at home. And some of our more universal patients, we might allow them to, or support them to carry on exercising themselves, but give them some advice about how hard they should be working, how often should they be exercising, what are the right kinds of things for them to do. From a psychological point of view, all of the patients that we've seen so far have been supported by the team through support from the team with the skills that we have within the team around psychological support and wellbeing for patients, and signposting to maybe resources and charities like Swallows or like some of the cancer charities in Sheffield or Macmillan. And then from a dietetic point of view, patients have been able to be given advice before their treatment and then linking into the Western Park Cancer Centre and the dietetic team in there. So either seeing patients a little bit earlier than they might have been, or making sure that they're seeing the right people. Some of our patients in this pilot have progressed through prehab, and we're supporting them in their treatment, and it's been a slightly different mix. So some, through treatment, are continuing to come to our group classes and coming to exercise regularly. We've got a component of fatigue support. We offer support for fatigue within our service, obviously particularly maybe with radiotherapy, that can be a particular issue. And so those patients going through treatment have the opportunity to access support with their fatigue. Some patients are exercising at home on their own. I think we've got one patient who's using our gym drop-in service, where we've got some staff in the gym in the leisure centre, and that patient is coming in and having a workout on a regular basis, but just with some oversight from the team. So a real mix. And I can't tell you what any of these patients are doing in rehab, because we're only a pilot at the moment, and none of them have got through that stage where they've got through to the end of their cancer treatment and moved into that rehabilitation phase. But I think it's really promising that they're continuing to engage with this through treatment, because we find it's those patients who pick up their exercise best after treatment as well. So for us, our next steps are to continue with this pilot, and we're expanding the pilot out. So having started with our more complex patients, we're opening up to, with our least complex patients, we're opening up to take on more complex people and to expand the numbers coming through to us. We're going to carry on reviewing our data and keeping an eye out on it. We had to submit these slides a few weeks ago. Somebody was talking about the research and research support. So although we're doing this as a service and as a service that we're evaluating, like I said, there's a Macmillan review going on at the moment about the current evidence, and that will be out in March about what evidence there is. I'm not aware of any other services that are delivering rehab in head and neck. If anybody is, I'd be really happy to hear about it, about trying to network and expand and talk about this more, so that this is open an opportunity to other people across the country. And we were talking just this week with a research group up in Cumbria who are looking to set up a research study of rehabilitation in head and neck cancers as well. So there is more going on. I think this is fledgling for now. I'd like to think that in a not too long, it's something that's available to every patient, to every head and neck patient, to every cancer patient. But for now, we're taking those early steps and looking to see how we can support our patients best, so that everybody can become somebody like Richard, who's been through treatment and is running a triathlon. That's everything from me. Thank you very much.
Okay, so our final speaker of this session is Samantha Gregory. She is a clinical lead for head and neck cancer SLT service at Torbay Hospital. She's a proud supporter and patron of the Swallows charity, and today she will be presenting her work on using the Iowa Oral Performance Instrument in the rehabilitation of patients' swallow function following treatment.
Sat on my notes and I've got a bump in it and I'm still Oh, let me. Okay. So I'm Sam. I'm a speech language therapist. I work at Torbay Hospital in South Devon. I'm going to talk to you about a device that we use in Torbay. Just to say a disclaimer, I'm not being paid to talk about this, but I did find the money to get it. So this is a device that Perry's very kindly mentioned earlier, that we help patients with swallow rehabilitation. So what is it? It's that. The IOP, we call it, Iowa Oral Performance Instrument. So it's a little bulb on the end of a pressure gauge, so that little blue bulb there, and the patient will pop it in their mouth, at the front of their tongue, back of their tongue, and we can also measure lip strength. And what it will give us is a measure in kilopascals of strength of the tongue is or the lips. So it's actually really helpful for us to see people that have gone through treatment, and we know they've got a weakness in their tongue or their throat, and we can actually measure that. Which to us, we love measuring stuff, don't we? Yes, that's great. So what it does, you can objectively measure tongue strength and endurance. So what we look at fast reps, because there's two different types of muscle fibres within the tongue. You've got the fast pulses and you've got the long squeezes. So we can measure both. And what's wonderful about it is it provides direct feedback to the patient as they're using it. It's really easy for them to use. It's quite motivating as patients come up and see us every week. We make it harder, but they see the results. Every time they come and see us, we measure their tongue strength. They can see their numbers going up. Once upon a time, so obviously we haven't always had an IOP, what did we do? You might have said, so absolutely what Kerry was talking about. We provide swallow exercises, we talk about diet modification, we keep people eating and drinking as best they can when they're having their treatment. But we know for some of our patients this is not possible. They just cannot eat and drink for whatever reason that might be. You might have seen us with our tongue devices. They actually do help. You might have seen us with our Oralite spoons. Again, they help, but what I've found is to assess and treat someone with these, how do we measure it? How do we know things are changing? We can ask the patient, absolutely. What we like to see is the patient will be telling us, well, eating and drinking is getting easier, I'm not coughing when I'm drinking as much, I've noticed that my tongue is moving more, and that's great, don't get me wrong, but how do we measure that as well? So what we did is, I'm quite good at getting money, as my colleagues will know, and we managed to get a grant from Macmillan in 2019 to buy the IOP device, the Pro, which is the black one on this side, and we managed to get 2 trainers, so they're the ones that the patients take home with them. The Pro is the device that we use as clinicians to measure the patient's tongue strength or lip strength and endurance, and then the trainer is what the patient takes away with them. So we've got a couple more buttons on ours, but what the wonderful thing about the trainer is the patient just takes it away, turns it on, and does their exercises. The way we got the money, I borrowed one, basically. So I had a patient that I tried everything that I possibly could to help them with their swallow, and it just wasn't working. So I borrowed one, and we tried it, and he loved it, and it worked. So I went to Macmillan and said, can we have some money? And they said yes. And we're really lucky to be able to buy this device. So I'm just going to show you 3 more pictures of it. So I was talking about the little bulb that patients pop into their mouth. So they pop the bulb at the front of their mouth. So we're looking at the anterior tongue. So the bulb will go between the tip of the tongue and the roof of the front of the mouth, just behind that sort of textured ridge. So we measure the front of the tongue. We also measure the back of the tongue. So where you would make a k, k, k sound. If you want to do lips, you put the bulb just inside here and you get the patient to squeeze on it. And what we do is we get the patient to squeeze the bulb as hard as they can 3 times in each position. It's a bit cumbersome, a bit slippy, can get a bit stuck. So that's why we like to do it 3 times, just to get an overall score. And some scores might be quite high, and you think, oh, is that in the right place? Or they might be biting on it. Or some scores might be quite low, so it's just thinking we're getting it in the right spot. So that will give us so basically it's what they can, you go into the gym, what you can lift in one go. How hard can you push your tongue in these points in your lips, okay? So why do we want that? Why do we want to know how strong their tongue is? So what it does for us is, what we started doing is we started taking tongue strength measurements before patients had their treatment. Why? Well, it's quite interesting actually, because out of pure curiosity for me, thinking about how strong our tongues are in people that have never had treatment, it's such a variation. So when patients come and they do the IOP with us, after their treatment, I have no idea what their tongue strength was before. So it's quite handy to have that. It's interesting for them to see as well. We get taken a bit more seriously sometimes when you've got a flashy thing and people can see exactly why we're talking. Because it's so abstract, isn't it, swallowing? We don't see it, we just do it. So actually to show people, this is what your tongue strength is today, this is where you sit within our normal data. So we do use it as part of our rehabilitation. So initially we will take a measure of the patient's, so usually we use it in tongue strength.
So following treatment, if they are to start the IOP programme, we take a measure on their first session. We then set them up with a therapy programme. I'll talk to you about that in a minute. Okay. And what I found is it assists with swallowing and speech. So we see patients that have had partial glossectomy, so part of their tongue is removed. They don't actually have a problem so much with swallowing, it's more their articulation. And we found by strengthening the muscles in the tongue, that actually has a knock-on effect on clarity of speech, which is great. So what the IOP lot did is they looked at lots of different people's tongue strengths, people that have never had treatment, and this is so once you've taken someone's measurements, they say, oh, how does that fit in with everyone else? Because we want to know where we sit, don't we? And for some reason, they've kind of classified it in 3 sections, which I won't tell you the age ranges, but so this is, if you've never had treatment, this is where your tongue strength would sit in a measure of kilopascals, and this is actually only the front of the tongue. For instance, my tongue strength is 69 kilopascals front and back. So I would sit in the middle range. And mine's kind of average, that's quite good. All my colleagues have had a little go as well. They sit within the... Some of them, one of them didn't actually, she was quite disappointed, so we maybe need to do some work. But it's very difficult when you show someone this normal curve when they just had part of their tongue removed, or they just had chemoradiotherapy and they stopped eating and drinking for 2 months and they've got awful secretions, and it's great having it, but actually what is that giving us? Actually what I would like to show our patients is, this is where you are now, let's get you stronger, move it on. So what do? What the trainer has, so for instance, say you can reach 10 kilopascals in one squeeze. We work on the sort of principles of exercise science. So it's great if you could lift 10 kilograms in one go, but you're not going to build up muscle by doing 1 rep. You need lower weight, higher reps. So that's basically what the IOP does for your patients. So we get their first measurement, say it's 10 kilopascals, and what we can do is we can set the device to be able to show the patient how to reach 60% of that. So I'll set that device to 6 kilopascals, and as the patient pops a bulb in their mouth and squeezes it, there's a little indicator light on the side that will go from amber to green. So as soon as they hit the green, they hit 6 kilopascals, so they know they're getting the right target. What the trainer also does is it will count for the patient. So what we normally say is you need to do 30 reps 3 times a day, 5 days a week. So, but how do you know they're getting the reps right? Well, it will only count it if you've got it right. So it can be quite mean to you. You set this device, I want to hit the green. So you can do as many reps as you want, but if you don't hit the green, it won't count it. We give them 2 days off. It's hard work, isn't it? Sort of thinking, this sounds great, but I've really got to sign up for this. I'm going to be doing this 30 reps 3 times a day, 5 days a week. How long am I going to be doing it for? Usually our patients will do it for 6 to 12 weeks. So it's quite a big sign up for our patients. They come and see us weekly. We recalibrate their IOP, so we retake their measurements and make it harder, basically. So we start at 60% of what they can achieve. We then go up to 75%. We then go to 80%. And they love it. Everybody just loves a challenge. And actually, interestingly, we only do the front of the mouth. So we only work the tongue at the front. But what we find is that has a knock-on effect to all the other muscles. Because what we're trying to do is strengthen the muscles in the tongue. As we know, the tongue is a massive driver for the swallow. But that's not the only thing that moves the swallow. All the other muscles in here work too. But what we do find is that the patients can feel it in their neck and at the back of their tongue as well. And as the anterior tongue numbers go up, so do the posterior tongue. And what we should be seeing is patients eating and drinking better. That's what we like. So something we also do before we start an IOP program, so we would do an instrumental assessment like Kerry was talking about, and in Torbay we're really lucky to have access to the FEES assessment, so when you pop a camera down someone's nose. So we usually FEES the patient before and we FEES them after. Really helpful for us to see exactly what's going on with that swallow, to see whether the IOP would be something that would work for them. And the patients love it as well, because when they come back for their FEES again, what you hope to see is eating and drinking gets easier as you go along the programme. Some patients can be quite reluctant to be trying other things because they've had instances of choking in the past. So repeating that FEES is really helpful because we can really push them on. And the wonderful thing about seeing them weekly as well is we can say, have you tried this? Have you tried this? What have you been up to? So we normally start the IOP, if we're going to start it, about 3 months following their treatment. We really hope people just get eating and drinking again naturally and with a bit of our help. For some people it's just not possible, and like we mentioned before, if they've had a really hard time with treatment and they've stopped eating and drinking altogether, we have to wait for things to settle down, but we want to get you eating and drinking as quickly as possible when you get back to normal. Some patients we've had have been 11 years post-treatment. So somebody that's been eating and drinking, but sadly eating and drinking has got more difficult due to muscles getting tighter, you're getting fibrosis of the tissues, and they are noticing problems with their swallow. And they love the IOP, we have really good results with it. Oh, okay, right, so this might work, this might not, I don't know. Let's just see. So if I press a button, one of these is going to move. Yes. Posterior tongue. Yes. Anterior tongue. There you go. Oh, that's great. So far, we have seen 24 people through an IOP programme. And then that's the sort of majority. The majority of our patients had a base of tongue cancer. Interestingly, somebody that had vocal fold cancer went on to develop a dysphagia as a result of their radiotherapy, more so than the fact that they had a vocal fold cancer. So most of our patients have had chemoradiotherapy. We do see some that have had surgical sections. Oh, okay, and here's our data, basically. So this is a bit of a busy graph, but I was just trying to think about how I could show you patients that have gone through this. What we have is we've got the front of their tongue, the anterior tongue pre and post. So, and then we've, in the first two colours, posterior tongue, pre and post, IOP. And we picked one of the measures that we use, it's called normalcy of diet. So what sort of things is the patient eating and drinking? Are they having a full diet with no restrictions? That would be 100 on our normalcy of diet. Are they having puree, which would be a 30? Quite a few of ours ended up on an 80, which is all meats with some restrictions. But what I loved about this is every single patient we've treated with it, it's worked and got them eating and drinking better. We can't fix it completely. What we love about it is the fact that it's just so visual for the patients. You can pick it up and do it and see that you're doing it. We can also tell if you're not doing it. So, what have we learned so far? I'm so proud to be a Macmillan professional because Macmillan is an absolutely wonderful charity, and the fact that they gave us the money to use this device, we're forever in their debt. We got the device and it took about 9 months to actually be able to use it because our trust had a lot of sort of hoops to jump through because this is a medical device. So just check if you're going to be procuring one of these devices with your procurement team, what you need to put in place, because we had it sat on the shelf for ages. It took ages to actually be able to buy it to start. We had the money, but then to buy it and then use it. So just come talk to me about that because I'm really good at go to this person. I don't know. And we found it's really useful for speech and swallow, so it can have a knock-on effect to articulation as well. I'm not a big fan of articulation drills, but I will do them if somebody would like to do them. But actually, I find this works better for me, for the people that I've seen. The patients find it quite easy to use, and it's encouraging for them to see their numbers going up, which we love. We chart it on a graph and write it down, and it's just lovely to take away and say, I'm now on this, I've gone higher, look how much stronger my tongue is. The thing that I did find, it's a big commitment for patients, so it is a lot to do those 30 reps 3 times a day, 5 days a week. So you really have to be engaged in it. Something else that we do use the IOP for is for patients that are having other swallow rehabilitation. I'll use it as a baseline again, because we've only got 2 devices. We can't give it to everybody. And when you have the IOP, and I'll trust you have it until you don't need it anymore. How do we know they don't need it anymore? Usually what happens is their numbers plateau, and it's usually about 6 to 12 weeks. We repeat a phase and hopefully demonstrate that the swallow's improved, and we agree with the patient that they don't need to continue. Some of them don't want to let it go. They're like, what do I do now? So what next? So we haven't used it actually, because we haven't had to use it, but we've actually got software that we can download onto our computer, so we can plug the IOP in and see what the patients have been doing, and see. So if numbers are not going up, why are they not going up? And if most people are honest, they haven't done it or not doing it, we can look at their technique, but we can actually download what they've been up to and do a bit of Big Brother on it. And what I love a baseline, and I love to be able to collect data. So actually collecting data pre and post treatment might be really helpful for us. I'm always interested to know what effects chemoradiotherapy and surgery is going to have on someone's swallow. And so actually for me, therapeutically, to be able to say, this is where you are today, this is where you were prior to treatment, this is where you are today, let's get moving with those swallowing exercises. I've got a little wonder whether it could be something we could use to help with our prophylactic exercises, because we give people exercises to do while they're having their treatment, but it's another thing to do, isn't it? And you just got to get your head down, take your painkillers, make sure your weight's stable, you're doing your mouth rinses, you're doing swallowing exercises. Would this be another thing to do? Don't know. And then the thought of prehab as well. Actually, if we can strengthen the body, can we strengthen the swallow muscles before their treatment? Will that have a better effect on their swallow? Don't know. Be a research project in there. So the IOP is great. I love it. It's not for everybody. We do other things, but it is a tool in our toolbox, I would say. So, thank you.
Just got a couple of minutes for any questions. If anyone's got something. No, not yet.
So this is the question for IOPI. So do you have any data to suggest that it is better in terms of compliance and outcomes regarding swallowing when compared with your conventional? Because it does come with cost strategies and it is for individuals.
Just come up here.
So we've got loads of data. We've got data from every single patient we see. We collect baseline data and outcome data for everyone. So if we want to compare it, absolutely we can. And this is great, but actually the majority of our patients do start eating and drinking naturally with a little bit of support. So this is where I would say more so in the group of patients that have got quite severe swallowing problems. But yeah, I've got loads of data if you want us to share any of it, absolutely. So.
Any other questions? Hello.
Well, I was just wondering if you've got any information or data about maintenance. So obviously, with a lot of the devices we use, we would use them for a period of time. The patients then have these back. Have you looked at kind of the longevity of the game at all?
Yes, we still see patients afterwards and we do check in with them. So we might not always do an IOP assessment with them at the time, but we do look at what they're eating and drinking and what their sort of own reported outcome measures are. We haven't had anyone come back for it. And I do say to patients, if you feel that your swallow has changed, come back to us, but that hasn't happened yet. And what we hope, in terms of maintenance, is eating and drinking will take over. So you kind of get the muscles to a point where you can eat and drink more, which will then challenge that swallow system anyway, which means that they can eat and drink better. And interestingly, our maintenance exercises that we do give out do work. So one of the ones that we give out to ask people to do is our Masako. So where you hold your tongue between your teeth and swallow. And interestingly, we've put the bulb in our, oh, we love doing this, if you put the bulb in your mouth and do your Masako, you will hit 80% of what your peak is. So reassuringly, we'll hopefully say to patients, actually, you can continue to do these exercises yourself and reach that higher target, even just by doing a Masako.
I think also with maintenance exercises, it's very individual as to what that person feels able to manage within their day-to-day life as well. So that's part of the factor in how frequently you're asking someone to do something which they're having to do every day or a few times a week. So,
one last question.
So regarding the prehabilitation, I was saying that in an institute, I'm from basically India, and I'm a head and neck surgeon, and we cater to huge number of head and neck patients. So I'm from Tata Memorial Hospital, which is in Mumbai, and there we see that we have in fact incorporated ERAS, that enhanced recovery after surgery, for our head and neck patients also. So that we have been using for our GA patients, but now we are doing it. So that also includes part of prehabilitation, where we do see our patients and we send them to almost all these rehabilitative services. So we do that, and we send for our the dietitian, we send to speech swallowing, we send to the physiotherapy department, the occupational therapy, and we do have this kind of system. I agree it's not possible for each and every patient because of the sheer load of the patient, but this can be done because that we do in the perioperative period, just immediately after surgery, and then in the post-operative period as well. So that is one way, like we do it as well.
Okay, thank you. And that just leaves me to thank all our speakers this afternoon. Thank you.
Thanks a lot. That was a really interesting session, and thank you to all of you for getting through the first day. The most difficult bit was the start, wasn't it, the video? So it was always going to get better. But I think it's been a really interesting day, and just hearing those patient stories and the problems they face, but also how inspiring some of those stories were as well, that they've taken adversity in their stride and now using their experience to actually help others. And I think that's what I want everyone to take home with them. Thank you to all the speakers who gave up their time and expertise and spoke to us. And it's been a real eye-opener. I've seen lots of discussions, people from different backgrounds, and also thanks to the sponsors, and for all of you for engaging with the sponsors. Also, it was really good to see that. One thing I forgot to mention in the morning was that we also had a big purple bus parked outside from Western Park Hospital, and they'll be here tomorrow as well. And that's a project that the Cancer Hospital here is doing in Sheffield, where the bus goes around Sheffield and some of the more deprived areas, and sometimes in shopping malls, etc. So people can just come into the bus. It's a private space and have a chat. whether they're worried about cancer, if they have cancer, or they might know someone who's got cancer. So they'll be here tomorrow as well, so make sure you do visit them and have a chat with them. And to those of you who will be joining us for dinner, I'll hopefully see you in 2 hours, and the rest of you, we hope to see you all again tomorrow morning. And thanks a lot, and enjoy your evening in Sheffield. Don't get too pissed.
No, I'm going to the president's dinner.